So we just heard one man's really amazing journey of going from shock to survivor of colon cancer at the very young age of 40 years old. So what we want to do is we want to talk about colon cancer and awareness. So with us today is Cone Health gastroenterologist Dr. Gabriel Manzarotti. And so let's talk about this. Let's start with the whole thing about age, because we just heard that someone was 40 years old. We're hearing more and more people who are younger are being diagnosed with colon cancer.
Yeah, certainly it's quite an issue that we're dealing with these days. It's actually a reason why in the last few years the guidelines actually dropped the age from 50 to 45. I think that because we do more colonoscopies these days, because patients are starting to think more about their symptoms, we're able to actually diagnose cancers a little bit earlier. But risk factors like obesity, diabetes are certainly risk factors that increase the risk several-fold for colon cancer. Patients who are Black, African American, are at an increased risk of colorectal cancer incidence and death from it, and early colon cancer. So previously we used to do them at age 45. Now everyone begins at age 45.
Okay, so you talked just a little bit about some people come in because they have signs or symptoms. What kinds of signs or symptoms are we talking about?
I think the most common symptom that I see is rectal bleeding. So be it red blood, maroon, purple blood, or black tarry stools. That is not a normal sign. Many times hemorrhoids are thought to be the reason. Patients just kind of let that be. But the longer we wait, sometimes we'll actually end up finding that patients become anemic, they get shortness of breath, fatigue, and over time that iron deficiency really can impact a person's daily activities, and that may be the inciting factor that tells them they want to go and talk with someone else or with their healthcare provider. Changes in bowel habits, diarrhea, constipation when you're pretty regular normally are other signs that we think of as changes that could be concerning for colon cancer development.
And you said, to talk about it, which, this is one of those things where a lot of people don't want to talk about their bathroom habits. They feel really uncomfortable about that. So what would you say to folks who are just like, yeah, I've noticed some things, but I really don't want to talk about it with anybody, and I don't know who to talk about it with?
Yeah, I think when patients get to our office already, they've already probably felt some sense of being scared, or they had someone that they've talked with to tell them this is not normal. For me as a provider, any patient who comes in, any sign or symptom is not too abnormal, not too weird to talk about. The sooner I know about a symptom, the sooner I can work on trying to resolve their issue.
When you say, we want people to be screened at 45, let's talk about what is screening.
Right. So there are different modalities of screening. Colonoscopy, as well as stool-based testing, are different forms of colon cancer screening. Colonoscopy for most gastroenterologists is felt to be the gold standard, because not only can we screen for a cancer that may already be present, biopsy, tattoo, and get them ready for potentially meeting surgeons or oncologists, we can also be preventative. If we find a polyp that is precancerous, we have the opportunity to remove it before it may ever become a colon cancer. So for most of us, colonoscopy is the gold standard, but Cologuard and FIT-based DNA testing as stool-based testing also have roles in our armamentarium.
Okay, and a colonoscopy, it's outpatient. You arrive at one time and you're going to leave like a couple hours later.
Right, so for like tomorrow, my patients who are going to start at 8 a.m. with me, they'll come in at 7, so 1 hour before the procedure. They'll meet my endoscopy nurses, they'll get their IV placed, they'll meet our anesthesia team, they'll come into the room, meet me, and I'll talk with them about the risk benefits, because many times I'm meeting the patient for the very first time, unless I saw them in clinic. We'll go over the procedure. We'll do the procedure, which takes about 20 to 30 minutes. They'll go to recovery. I'll come and talk with them about what we found, saw, and did with their family member or caretaker, give them a picture report, and then based on the pathology that may be pending, or if they had a normal colonoscopy in our average risk, they'll be good for 10 years. If they have polyps or other pathology, that may mean they may have to come back sooner.
Gotcha. So not as a long, drawn-out process as you might expect, but we're going to talk about what leads up to that colonoscopy. That's coming up next.